Imagine you're standing in the middle of a really high-stakes intensive care unit.
Right, the ICU.
Yeah, and the rhythmic, steady beeping of the monitors is, essentially the soundtrack of the room. It kind of lulls you into this false sense of security.
Oh, absolutely. Almost hypnotic until, well, until it isn't.
Exactly. Suddenly, an alarm changes pitch. A patient's blood pressure has just absolutely crashed. And in that moment, the clock starts ticking.
Yeah, you have mere minutes.
Right. The medical team has mere minutes to restore that pressure before the brain, the kidneys, and, well, the heart itself are irreversibly starved of oxygen. So how do they actually pull someone back from the brink of circulatory collapse?
It's a terrifying scenario to witness, but it's a reality that plays out every single day in hospitals around the world. And the answer to that crisis usually comes in like a small, unassuming 5E bag.
It's just a standard high-V bag.
Yeah, but it contains some of the most potent, precisely engineered molecules in modern medicine.
So, to figure out how doctors actually pull patients back from that brink, we are diving into a stack of your sources today. And this is a true deep dive, ranging from, the wild medical history of the 1890s to landmark critical care trials.
And of course, the physiological principles that govern our bodies every day.
Right. So our mission for this deep dive is to explore the fascinating pharmacology of those life-saving drugs. They're kind of vasopressors.
It really is a masterclass in human physiology. I mean, when you boil down the complexity of the human body, surviving that ICU scenario rests on one fundamental equation.
Oh, the math part.
Yeah, but it's the first thing every critical care clinician memorizes. Meaning arterial pressure equals cardiac output multiplied by systemic vascular resistance.
Okay, let's unpack this, because saying, MAP equals CO times SVR sounds a bit like high school physics.
It does, yeah.
But it's literally the math keeping us alive right now. So if we think about the cardiovascular system, it's basically a highly advanced plumbing network.
That's a really good way to look at it.
Think of it like a garden hose. If the water pressure in that hose, which is your mean arterial pressure, drops too low, you essentially have, two ways to fix it.
Right, you have two distinct dials you can turn to restore that pressure.
Exactly. Dial 1, you turn up the faucet, you make the pump push more water through the hose, and in the human body, that means increasing cardiac output.
Doctors do this by, giving IV fluids or using drugs called inotropes to sort of whip the heart muscle into pumping harder and faster.
But dial 2 is where our topic lives today. If you can't turn up the faucet anymore, you put your thumb over the nozzle of the hose to, squeeze the flow.
You physically increase the resistance.
Right. That is systemic vascular resistance. And vasopressors are basically the chemical thumb on the nozzle.
That analogy perfectly captures the mechanics, honestly. A vasopressor pushes that blood pressure back up to a survivable level by clamping down the vascular tree.
And I think this is wild, how we actually figured out how to squeeze that nozzle pharmacologically is a completely different story.
Oh, yeah.
Yeah.
We didn't arrive at these life-saving IV bags through, elegant, targeted computer modeling.
Not at all.
The discovery was entirely accidental over a century ago, and it was incredibly chaotic.
So take us back to that chaos. We're looking at the 1890s here, right?
Yep, 1894 to 1895.
Because the contrast between today's sterile ICU and how this started is just mind-blowing.
It really is. We have to travel back to University College London. Two physiologists, George Oliver and Edward Schaefer, are running experiments on anesthetized dogs.
Wow, okay.
It's the Wild West of medical research. They decide to take extracts from the adrenal glands of animals, mash them up, inject this raw slurry into the dogs, and simply observe what happens.
They just injected a raw gland smoothie into the dogs.
Basically, yeah. And to their absolute shock, they watched the blood pressure dials completely spike.
That is crazy.
They didn't even know what the active chemical compound was yet, but they had just stumbled onto the massive systemic vasoconstrictor power of what we now know as epinephrine.
Or, as most people call it, adrenaline.
It's exactly. Adrenaline.
It's just wild to think about injecting raw gland extract and just watching the physiological fireworks.
Right. But that raw discovery kicked off a massive international scientific race to figure out what that chemical actually was.
And they figured it out pretty quickly, right?
They did. By 1901, a Japanese-American chemist named Yukichi Takamine managed to isolate and crystallize the active ingredient. He pulled epinephrine straight from bovine adrenal glands.
Wow.
And he actually patented it under the trade name adrenaline. This was a huge monumental achievement because it was one of the first hormones ever isolated in a pure form.
So it was like a blockbuster drug.
Oh, a massive blockbuster drug of the early 20th century. And the timeline moved really fast after that. By 1904, a German chemist named Friedrich Stolz achieved a full chemical synthesis in the lab.
So within a decade, doctors go from relying on cow glands to having a standardized synthetic vasopressor in a bottle.
Pretty much, yeah.
But epinephrine is famously the fight-or-flight hormone. It's the panic button your body hits when you're terrified. What about the body's normal, everyday control over our blood vessels?
Well, that piece of the puzzle remained a mystery for another 40 years, actually.
Really? 4 decades?
Yeah. It wasn't until 1946 that a Swedish physiologist named Ulf von Euler identified a closely related molecule. It's called norepinephrine.
Oh, you know, epinephrine.
He discovered that norepinephrine is the primary neurotransmitter of our sympathetic nervous system. It isn't just dumped into your blood when you're chased by a predator.
So it's not just an emergency thing.
Not at all. It is continuously released by nerve endings to maintain your normal vascular tone every single minute of your life.
Yeah.
Like as you're listening to this, standing up or walking around, norepinephrine is the reason all the blood doesn't just pool in your legs.
Which totally reframes how we view vasoconstriction. It's not just this, emergency reflex. It's an everyday regulatory system. And clinicians eventually realized they could chemically hijack this system. But how does that hijack actually work? Like, if we aren't literally putting a thumb on a hose, how does a chemical floating in the blood force a muscle to clamp down?
So we are targeting highly specific cellular receptors. Most vasopressors work by binding to something called alpha-1 adrenergic receptors.
Alpha-1 receptors, got it.
Think of these receptors like little doorbells, right? They're located on the outside of the smooth muscle cells that long your blood vessels.
Okay, so the drug floats by and just rings the doorbell.
Yes, exactly. And when that alpha-1 doorbell is rung, it sets off an internal alarm system inside the cell. In pharmacology, we call this a GQ protein cascade.
Sounds intense.
It is.
Yeah.
But you can just picture it as biochemical first responders rushing into action. This internal alarm system forcefully triggers the release of a massive flood of calcium from storage inside the cell.
Ah, calcium.
Yeah. And calcium acts like the physical bouncers in this scenario. It forcefully grabs the muscle fibers and makes them contract, pulling the walls of the blood vessel tighter and tighter.
Wait, I'm going to pause you there because that makes me wonder something.
Sure. What's up?
If the ultimate goal of all of this is just to, ring that alpha-1 doorbell, release the calcium bouncers, and squeeze the vessel, why is the hospital pharmacy stocking a dozen different drugs for this?
That is a great question.
Like, why not just manufacture one super pure drug that only rings the alpha-1 doorbell and completely ignores everything else?
It's a very logical assumption. And, well, we do actually have pure vasopressors in the toolkit.
Oh, we do?
Yeah. A drug called phenylephrine, for instance, is a pure alpha-1 agonist. It only rings that specific doorbell.
Okay.
There's another called vasopressin, which uses a completely different receptor pathway, but it also achieves a pure vascular squeeze without affecting the heart.
So why not just use those all the time?
Because purity is not always the goal in medicine. This is where the textbooks get a little complicated because many of the most crucial, life-saving vasopressors are actually very messy.
When you say messy, you mean like they are ringing other doorbells at the same time.
Exactly.
Yeah.
Take norepinephrine, that everyday neurotransmitter we just talked about.
Okay.
It rings the alpha-1 doorbells in the blood vessels, providing a great squeeze.
Right.
But it also wanders over to the heart and stimulates beta-1 receptors. Beta-1 stimulation acts on that other dial we discussed, the faucet.
Oh, so it affects the pump, too.
Yes. It increases the heart rate and makes the heart muscle contract harder.
Ah, okay. So you're getting a strong squeeze on the hose, but also a gentle bump to the pump, pushing the water.
Precisely. This dual action is so common and so useful that intensivists use a hybrid term for it. They call it an inopressor.
Inopressor, okay.
Yeah. It's a blend of an inotrope, a drug for the heart, and a vasopressor, a drug for the vessels.
What's really fascinating here is how matching that specific messy receptor profile to the exact type of crisis the patient is experiencing is how you actually save their life.
Yeah, that is the whole art of it, yeah.
So let's look at a real-world example outside the ICU. Anyone with severe allergies knows about the EpiPen. When someone goes into anaphylactic shock from, like, a peanut allergy or a bee sting, they use an EpiPen, which is just a shot of epinephrine. Why is epinephrine's specific messiness irreplaceable in that moment?
Well, anaphylaxis is a terrifying dual system failure. On one hand, the massive allergic reaction causes your blood vessels to wildly dilate.
So the blood pressure just drops.
Exactly. The pressure plummets, leading to vascular collapse. But simultaneously, the smooth muscle around your airways aggressively constricts, meaning you can't pull air into your lungs.
So if you gave them that pure vasopressor you mentioned earlier.
Right. If you gave them a shot of pure phenylephrine, it would certainly clamp the blood vessels and fix the blood pressure.
But the breathing.
The patient would still tragically suffocate because phenylephrine does absolutely nothing for the lungs. Epinephrine is life-saving specifically because it's a multi-tool.
Right.
Its alpha-1 action fixes the blood pressure drop, while its beta-2 action actively relaxes the smooth muscle in the airway. It physically opens up the lungs so you can breathe again.
Wow.
Yeah, you need that messy profile to survive.
You need the exact right key for a very complex lock.
Precisely.
Let's apply that logic back to the ICU, specifically to septic shock, which your sources highlight as one of the leading causes of hospital deaths globally.
It's a huge issue, yeah.
What is physiologically happening to our plumbing system during sepsis?
So in septic shock, a severe infection, usually bacterial, releases toxins into the blood. The body mounts this massive system-wide inflammatory response to fight it.
Okay.
But this inflammation causes profound vasodilation. The blood vessels essentially lose all their tone and just go completely slack.
It's like trying to fill a water balloon, but the rubber of the balloon has degraded and just keeps stretching and expanding.
That is exactly it.
You could keep pouring IV fluids into the patient, trying to fill the tank, but you're never going to build up any life-sustaining pressure because the container itself just keeps slackening.
That is the perfect way to visualize it. You don't just need more fluid, you desperately need to shrink the balloon back to its normal size.
Right.
And for a long time, the medical community fiercely debated the best way to do that. The two biggest contenders for the first-line treatment of septic shock were dopamine and norepinephrine.
Which brings us to the SOAP2 trial from 2010. This was a massive turning point in the sources.
Oh, the SOP2 trial was a huge landmark moment. Researchers randomized over 1,600 patients in shock to receive either dopamine or norepinephrine as their initial vasopressor.
And the whole critical care world was watching this.
They really were, and the results completely reshaped international guidelines.
Because it didn't go well for dopamine at all, did it?
It did not. While the overall mortality rate at 28 days was similar between the two groups, dopamine caused significantly more collateral damage.
Like what kind of damage?
Specifically arrhythmias. Dangerous irregular heartbeats. 24.1% of the dopamine group experienced arrhythmias, compared to just 12.4% in the norepinephrine group.
That's almost double.
It is. Furthermore, in a subgroup of patients who were in cardiogenic shock, meaning their heart pump was already failing, dopamine was associated with a higher death rate.
So let's look at the why there. Like, if dopamine is supposed to be helping, why is it causing the heart to misfire like that?
It all comes back to the receptors. To get enough vascular squeeze out of dopamine, you have to use relatively high doses.
Okay.
But at those doses, dopamine aggressively hammers the beta-1 receptors in the heart. And remember, a patient in shock is already starving for oxygen.
Right. Their heart is exhausted.
Exactly. Pushing a drug that aggressively whips that tired, oxygen-starved heart to beat faster and harder is literally like whipping an exhausted horse.
It just stumbles.
It stumbles.
Fish mode.
The electrical system of the heart descends into chaos, and that causes those arrhythmias. Norepinephrine, on the other hand, provides a massive, reliable squeeze on the vessels with only a gentle nudge to the heart.
So norepinephrine becomes the undisputed champion for shrinking the balloon in septic shock.
It really did.
But, you know, if you're the doctor staring at the monitor, human nature kind of kicks in. If squeezing the vessels gets the blood pressure back up to a survivable level, the logical assumption is that squeezing them more to get a nice high healthy blood pressure must be even better.
This raises a very important question, and it is a trap that clinicians have to actively train against.
Really? A trap?
Yeah. In critical care, there is a widely accepted target floor, a mean arterial pressure of 65 millimeters of mercury.
Okay, 65.
Right. Below 65, the pressure isn't strong enough to push blood into the tiny capillaries of your vital organs. Your brain, your kidneys, and your gut start to sustain ischemic injury. They are slowly dying.
So 65 is the absolute floor to keep the organs alive. But, you know, as a listener, ask yourself if 65 is the bare minimum, wouldn't pushing that number to 85 give you a much safer cushion?
We actually have concrete empirical data on this because researchers tested that exact assumption in the 2014 sepsis-PAM trial.
Oh, perfect. So they actually ran a trial on this.
They did. They took septic shock patients and randomized them into two groups. one with a standard target MAP of 65 to 70, and another group with a high target of 80 to 85.
Did the higher pressure save more lives?
It did not.
Yep.
There was absolutely no difference in overall mortality at 28 days or 90 days.
Wow, none at all.
None. But here is the critical part. Pushing the pressure higher was not a free lunch. The patients in the high target group who required higher doses of vasopressors experienced a significantly increased risk of developing new onset atrial fibrillation.
So by artificially squeezing the system harder just to make the monitor look better, you didn't save the patient, but you did induce a brand new heart rhythm problem.
Exactly. Pushing more pressure into the system inherently stresses the heart. 65 is an evidence-based floor, not a number you try to wildly exceed just because you have the pharmacological power to do so.
Here's where it gets really interesting, because the history of these drugs is just absolutely littered with persistent medical myths.
Oh yes, so many myths.
Things that made total, beautiful sense on a physiological chalkboard, but when finally tested in reality, turned out to be completely false. I want to talk about the most famous one in the sources, renal dose dopamine.
Oh man. This is perhaps the ultimate cautionary tale in modern critical care.
Right.
For roughly 30 years, it was standard practice across ICUs worldwide to run a very low continuous dose of dopamine, around 1 to 3 micrograms per kilogram per minute for patients in shock.
30 years.
30 years. The prevailing theory was that at these microdoses, dopamine acted differently. Doctors believed it selectively dilated the specific blood vessels feeding the kidneys.
So the narrative being, while the rest of the body is burning down in a shock crisis, we're using this tiny drip of dopamine to send extra protective blood flow to the kidneys to stop them from failing.
Exactly.
I mean, it sounds incredibly elegant.
It sounds perfect. It is physiologically plausible based on receptor theory. And because it made so much sense, it was taught as absolute gospel in medical textbooks for an entire generation. But it was entirely a myth.
Completely false.
Completely false. In the year 2000, the ANZICS Clinical Trials Group finally decided to put this 3-decade-old practice to a rigorous empirical test. They ran a randomized controlled trial with over 300 critically ill patients.
Then the results?
The low-dose dopamine did absolutely nothing. It had zero effect on preventing the need for dialysis. It didn't improve kidney function tests, it didn't shorten ICU stays, and it certainly didn't improve mortality.
That is just wild.
Yeah, renal dose dopamine survived for 30 years on theoretical charm alone, without a shred of empirical evidence proving it actually worked in humans.
That is wild. And there's an even darker history with norepinephrine itself.
Yeah.
Today, it's the gold standard. But the sources show that for a long time, it had a terrifying reputation among doctors.
It really did.
It was marketed under the brand name Levofed, and it earned the incredibly grim hospital nickname, Leave 'em Dead.
It is a genuinely dark era of medical history.
Yeah.
You see, in the mid-20th century, we simply didn't have the advanced hemodynamic monitoring that we have today. Clinicians didn't fully grasp a core principle. A vasopressor is absolutely useless and, in fact, highly dangerous if the patient doesn't have enough fluid in their system to begin with.
So going back to our garden hose, if the city turns off the water main, squeezing the nozzle doesn't miraculously create pressure.
No, it doesn't.
It just blocks the tiny trickle of water that's actually left.
That's precisely what was happening. Doctors were giving Levof, this massively potent vasoconstrictor, to patients who were profoundly dehydrated or actively bleeding out.
Oh, no.
By violently squeezing an already empty vascular system, the drug essentially panicked. It shunted whatever tiny amount of blood was left away from the extremities in a desperate bid to keep the heart and brain alive.
Which means the extremities are literally starved of oxygen. The sources describe patients surviving the shock only to have their fingers, their toes, and sometimes whole limbs turn black and necrotic, requiring amputation.
Yes, it was horrific.
Yeah.
And the horrors didn't stop there.
There's more.
Yeah. If the IV line leaked and this incredibly caustic vasoconstricting drug seeped out of the vein and into the surrounding tissue of the arm, a process called extravasation, it would clamp down the local blood vessels so hard that it would cause severe tissue necrosis right there on the spot.
Wow, just locally.
It would kill the flesh, so leave him dead. Wasn't just dark, cynical humor. It reflected the catastrophic outcomes of misusing a drug we just didn't fully understand yet.
And knowing that terrifying reality makes the next debate make total sense, because that fear of necrotic limbs forced hospitals to create a rigid, non-negotiable rule about exactly how these drugs had to be delivered to a patient.
Right. Because of those severe historical injuries, it became an absolute dogma that vasopressors could only ever be administered through a central venous catheter.
The central line.
Exactly. A central line is a long, deep IV that is threaded into a massive, high-flow vein in the neck or the chest. The idea was that the high blood flow in the chest would instantly dilute the caustic drug, preventing it from destroying local tissue.
But placing a central line isn't like, popping an IV into the back of a hand. It's practically a surgical procedure.
It takes significant time and skill, yes.
You're in a high-stakes emergency, the patient's blood pressure is actively crashing, organs are dying by the second, and the dogma said you had to stop and take 15 or 20 minutes to meticulously place a deep line in the neck before you could give the life-saving drug.
And we now know that delay literally costs lives. This is a massive paradigm shift happening in critical care right now.
Really?
Yeah. Observational data, most notably the 2015 CHASE study, fundamentally challenged this decades-old dogma. The study showed that if you use a large-bore IV in a big proximal vein like in the upper arm and you monitor the site closely, you can safely give vasopressors peripherally for short durations.
So the new protocol is start the drug immediately through a regular IV to save their organs right now, and then you can take the time to safely place the central line for the long-term drip.
Exactly. It's a complete reversal of teaching. We are finally prioritizing immediate, life-saving treatment over theoretical fear of tissue damage, which modern data shows is actually quite rare with today's monitoring protocols.
And just to prove that this century-old field isn't resting on its laurels, your sources highlight a completely new wave of drugs arriving in the ICU. Like, we aren't just relying on tweaking adrenaline anymore.
We aren't. In 2017, the FDA approved a drug called angiotensin II, marketed as Giapreza, based on the ATHA-3 trial.
Giapreza, okay.
What is truly remarkable here is that it bypasses the adrenergic receptors entirely. It completely ignores those alpha and beta doorbells we talked about earlier.
So it uses a totally different mechanism.
Exactly. Instead, it uses a totally different biological highway called the renin-angiotensin-aldosterone system.
Why do we need a new highway, though?
Because sometimes, in severe prolonged shock, a patient's alpha receptors basically burn out.
Oh, they just stop working.
Right. They become desensitized and stop responding to norepinephrine. We call this catecholamine refractory shock. When those doorbells stop working, Giapreza allows us to go around to the back door and squeeze the vessels from a completely different molecular angle.
That is brilliant.
It proves that even after 100 years of using pressors, we are still mapping new pharmacological pathways to keep the hemocirculatory system from collapsing.
So we've gone from injecting raw dog adrenal extracts in the 1890s to synthesizing pure molecules to precisely targeting alternative molecular pathways today.
It's an incredible journey.
It really is. But despite all of that sheer brilliance, there is one massive core misconception that we need to clear up as we wrap up this deep dive.
Yes. If we connect everything we've discussed to the bigger picture, the absolute most critical thing for anyone to understand is this. Vasopressors do not treat the underlying disease.
They are not a cure for anything.
They are purely a temporizing bridge. If a patient is dying of septic shock, the vasopressor artificially keeps the brain and the kidney supplied with blood, but it does absolutely nothing to kill the invading bacteria.
Right.
A patient can have a picture-perfect blood pressure of 120/80 on the monitor because the intensivist has the vasopressor dial set perfectly, but that patient can still be actively dying of an untreated infection.
The actual cure is the antibiotics for the sepsis, or, the surgery for the trauma, or the blood transfusion for the hemorrhage. The vasopressor just buys the doctors the time to let the actual cure work.
That's exactly it.
So what does this all mean for you, the listener? Why should you care about obscure ICU pharmacology? Because, well, this isn't just hospital trivia.
Not at all. These concepts filter down into everyday medicine.
These drugs are everywhere. If you or a partner has ever had an epidural during childbirth, the anesthesiologist almost certainly had a syringe of phenylephrine ready to counteract the sudden blood pressure drop that the spinal anesthesia causes.
Very common.
If you have a severe allergy, that EpiPen in your bag is a vasopressor. During the height of the COVID-19 pandemic, massive numbers of patients went into severe vasodilatory shock, creating a terrifying global strain on our supplies of norepinephrine.
Yeah, that was a really scary time.
This is the highest stakes toolkit in modern medicine, and it touches all our lives.
It truly is the ultimate physiological tightrope walk between life-saving intervention and profound harm.
Which leaves me with a final thought for you to mull over. We talked about how renal dose dopamine was universally accepted as a kidney-saving miracle for 30 years, entirely based on theory, until it was proven utterly false.
Yep.
We talked about how delaying vasopressors to place central lines was undisputed gospel until we realized it was costing lives. So as you think about that complex medical machinery, the alarms, the beautifully complex physics of the human body, wait, I mean, if we think about all of that, ask yourself what widely accepted standard of care in medicine today that your doctors absolutely swear by will the medical students of tomorrow look back on as just a well-intentioned myth?